Let me do my introductions. Good morning. Welcome, everybody, or one person. I can't even read. January 15th. Let me take off this mask. January 15th, and this is week 2, and this is MED265, and we are in the EKG portion of the show. Remember that the EKG portion of the show is the first 5 weeks, and then the invasive procedures, aka phlebotomy, is in the last 5 weeks. So as a quick review, what did we go over last week? We went over the, the role of the EKG, basic internal and external structures of the heart, arteries versus veins versus capillaries, and the conduction system of the heart. Okay, we now know what an ECG machine is. What is due today? Your discussion, which is essentially the answer, what are the risk factors for a myocardial infarction? And does our patient here have any, or does it look like our patient here has any genetic predisposition? The short answer of that is of course, the number one is always hypertension. We're always, because if your blood pressure is elevated above 120/80, that as an adult, that's a problem. And we're also looking at remember I mentioned in other classes that your genetics also predisposes you to certain behaviors. For example, he was a previous smoker. In the Garais family, it took decades for the Garais men to stop smoking. And even to this very day, the latest generation still either smokes, vapes, or drinks. But they're getting less and less in number because of, schools and education is promoting less and less drinking, less and less smoking. But man, I remember a time when I was a kid, the whole room would be full of smoke and be full of drink because the predisposition of the generation before it. But happy to say, my 2 adult kids never, they don't smoke, and they're only very casual drinkers, which is very, very odd. You can also see that he has a lot of stress and fast food, okay? Remember, the way you eat is also, in a way, it's a debate in regarding diabetes mellitus. The way you eat and the who taught you how to eat, of course, it was whoever took care of you, most likely your parents, right? Or some family member. So there's a debate in medicine that, is it really genetic or is it behavioral? But we already now know 40% of your behavior is genetic. And that is a proven fact by the American Psychiatric Association. So it's something to think about, okay? He has CAD. He's diabetic. Hypercholesterolemia, which is also known to run in families. And beware of hypercholesterolemia. You could be thin as a rail. My uncle Nestor, he was a twig the day they put him in a coffin, and his cholesterol was worse than my father, me, and his other brother put together. He was awful. And he, just like my father, had 2 double bypasses? And again, back to the history, smoker, drinker to the day he died, right? So you could see that the ECG, it is a diagnostic tool, but it's a diagnostic tool to help. And you could see that the history alone, since I'm in internal medicine, I'm a little bit biased regarding tests. The history alone already tells you stuff. And you could see here, this is your classic CAD or cardiovascular disease, coronary artery disease patient. This is classic, okay? So let's, again, that's due today, your discussion. And also, and make sure you did your quiz. There are some reports that you don't see your score online or whatnot. If you can't see it, of course, shoot me an email. And as I was mentioning earlier, you can't, especially for at least me, right? You can't say I didn't communicate. I am on this thing. So if you miss, and this is little, because I got a little irate call this morning about a student that says, no one called me. And I go, and he's saying, oh, I emailed you. I have no record. It goes, oh, I called you. I have no record of this person ever calling me. We save all our emails. We save all our calls. So if you don't hear from me, I'm either dead or it goes, I didn't get it. So, and have that same attitude with every other department here. If you don't get an answer within 24 hours, call again, and also add somebody else to that call list, so someone can get a call out to you. Now, those of you who did not have MED 140 or what's it called? Don't know how to do blood pressure. Blood pressure is always preceded before you do an EKG, because it's part and parcel of the telemetry notes. And what's telemetry? Tele means like, telephone. Meter means to measure. So when we send information, including the EKG, one of the main informations is the vital signs. So right here is a real quick review regarding blood pressure. So over the weekend, if you don't remember, look up your normal blood pressure values, and also know how to know the classic questions that I would typically ask from MED 140. And if you've never had that, please stay on after the lecture, and we can review it. What's due next week? The discussion, right? Right here. And remember, 200 to 250 words. Please don't write a book, right? And reflect in your role and what expectations you have. And it's pretty straightforward. And of course, another quiz right here. So let's jump into this little extra here on ECG equipment. Okay, and just for the record, Ms. Witchen, Ms. Phoebe, and I keep on forgetting Ms. Pooh. Ms. Pooh, can you put in the chat? I keep on forgetting your code on who you are. I forgot you the other night as well, but as you saw, I got your attendance. So kindly put it in the chat so I will remember it forever. So I believe that's all of you. And let's go into this ECG equipment. So this is the machine. And we're going to also be talking about the leads, okay? And what are in common of most ECG machines. We're also going to be talking about the paper. Last week we said we're going to be talking about the boxes, okay? Let's make the slideshow. Let's run it. So it'll be nice and big. Okay, now when you look at all the little waves, it is from 12 different viewpoints or 12 different cameras. Those viewpoints and those cameras are called leads. Okay, because there are 10 wires. There are 6 of them on your chest, and those are your precordial leads, right? And there are 4 of them that are connected to your arms and legs, and those are your limb leads, because those are your limbs. So 6 chest leads, 4 limb leads, okay? And all of them are attached to electrodes. Now, the ECG doesn't deliver any electricity. It monitors the electricity. So sometimes the patient might be concerned, like they might mistaken the ECG for a defibrillator. Defibrillator, that's the thing that sends out shocks. That's kind of a little bit on the dangerous side. But the ECG is perfectly safe, and you shouldn't get zapped by it unless, there's exposed wire or something. But in the 25 years I've been doing ECGs and teaching it for 20 years, no one's ever been electrocuted. Okay, so where are your limb leads? Your limb leads, and you could see before they used to be color coded, but they got these little letters on it. So RL goes to your right leg, LA goes to your left arm, RA, LL, so on and so forth. V1 through V6, those are your precordial leads. Those go on your chest. And I hope they're gonna talk about where they're gonna go. Okay. So those 10 wires, the 6 on your chest and the 4, so those electrodes or the little stickies that connect to those alligator clips, they will produce 12 different views. 3 standard leads, 3 augmented leads, and 6 chest leads. We're going to show you that now. Now this right now is going to make you crazy. You're like, what the heck is this? Right? Don't look at this now. But we'll look at it after we're all done. This is the summary of all the directions or all the viewpoints or all the cameras of all 12 leads. And some German cat named Einthoven created it. And the way he figured it out is that if your heart's here and I see it from 3 different perspectives, I can get multiple viewpoints, okay? And that's why they call it Einthoven's Triangle, and I'm gonna show you that in a minute. So, isoelectric, positive. Now, what does this mean? Right? Isoelectric means, iso means the same. That's a flat line. That's not a good thing, but there are parts of the wave that are flat. There are parts of the wave that shoot upwards. And there are parts of the wave that shoot downwards. So if they shoot upwards, right, that means the electrical flow is headed towards that camera or towards that lead. If it's a negative or downward wave, that means that electricity or the action potential is headed away from that camera, okay? This is an important point, and we're going to show that. Now, these are your standard limb leads. You have lead 1, lead 2, lead 3. They're your standard limb leads, and they're also called bipolar leads. And they're called bipolar leads because there's 2 poles. There's a negative and a positive. So lead 1 is your right arm to your left arm, right? And it always goes from negative to positive. So lead 1 is the camera or the lead or the viewpoint that's pointing from your right arm to your left arm. Lead 2 is from your right arm to your left leg. Lead 3 is from your left arm to your left leg. And when you put it all together, didn't that form a triangle? You have one going on the top, one going to the left side of your body, and then one going to running across from your right arm to your left leg. And that forms a triangle. Hence the term Einthoven's Triangle. Now, those are your standard limb leads. They are in Roman numerals 1, 2, and 3. They're bipolar because they have a negative and a positive, and it always runs from negative to positive. Now, you may be paying attention and may be asking yourself, wait a minute, Dr. Garais, we never talked about the right leg. Well, the right leg is your ground. Now, the ground wire, just like that extra third, hole inside, your light socket, all electricity loves to flow back into the ground. That's why, when you see lightning hit a tree, it hits the top of the tree and then it runs straight to the ground. And that is the ground wire. So your right leg is always the ground wire. Therefore, your right leg does not participate in Einthoven's triangle, nor does it participate in the ECG trace. Its function is a ground wire to complete the circuit. Okay? And looky here. See how it forms a triangle? Right? And remember, you're looking at this from the perspective of your patient. So if I'm looking at my patient, their right arm is over here, their left arm's over here, right? Their right arm is over here, their left leg is over here somewhere, okay? Now you could see if I have a problem with the top part of my heart, lead 1 is going to show it. If I have a problem that's running right through the center of my heart, lead 2 is going to show it. And do you see lead 2 from your right arm to your left leg? It goes right through the center of your heart. And lead 2 is also when the trace goes really long, it's also what we call the rhythm strip or the rhythm lead. And don't you think that's the best lead to tell a good cross section? So that's the one that we're going to talk about when we talk about arrhythmia or a dysrhythmia. You know, when the beat isn't lub-dub, 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 when it's not steady. So lead 2 is also known as your, and your long lead 2, the one that runs the longest, that will be your rhythm trace, okay? And of course, lead 3, if there's something wrong with the left side of my heart, let's say, for example, my patient is having left ventricular hypertrophy, where do you think they're going to pick it up the most? It's going to pick it up at this camera or this lead, which is lead 3. So those are your standard limb leads. So I could ask you, what does lead 1 connect to? What does lead 2 connect to? What does lead 3 connect to? Which one is your rhythm trace? This one, okay? Augmented leads. Now, augmented leads are easy because they are unipolar. They only go one direction. They start at the heart and then they fan out. And when you look at it, they all start with a little a. Now, we call them augmented leads because in the real world, the electricity that gets detected by the augmented leads is very, very small. So the EKG machine exaggerates these leads so that we can read them. So your AVR is the augmented lead. That's the one that goes from your heart to your right arm. AVL goes from the heart to your left arm. AVF goes from the heart to your left leg. And remember, the right leg is the ground. It does not participate in this lovely triangle. Okay. I just went through that. And this is what it looks like picture-wise. So it's unipolar. It only goes one direction, from the heart to wherever it has to go, right? So AVR goes to the right arm. AVL goes to the left arm. AVF or AVF, I think AV foot, F for foot, and the only foot we're going to be playing with in this triangle is your left leg. And now, do you notice all the arrows? If I put them all together, you would get that complex bunch of arrows that we saw earlier. Okay, so those are your limb leads, right? You have your unipolar and your bipolar, right? Now, these are the chest leads, okay? So those are, we talked about 3 and 3, that's 6. And of course, on your chest, there are 6 more leads. And that'll make it a total of 12 leads, or a 12 lead or a 12 viewpoint ECG. Also known as your precordial leads. They're specific sites on the chest. They're numbered V1 through V6. Now, do you see how, if you look at from like a top view, how it kind of like surrounds the heart? So if I have an anterior portion, or even a right anterior problem, like cor pulmonale or right-sided heart failure, right? Also known as congestive heart failure. Don't you see how I'm going to see it in V1 and V2? And remember that guy we talked about who had left ventricular hypertrophy? You're going to see it more on V5 and V6. So you see how it like curves around? And it starts up here in your fourth intercostal space, but we'll talk about that momentarily, right? So these are the chest leads. So they're going to look at the front part of the heart and the side left, okay? These leads are also, just like the augmented leads, unipolar because they only point inwards toward the heart. And you could see it forms a picture or a viewpoint of a specific part of the heart, okay? So this is an example of a 12-lead ECG, and you could see it has the patient's name, patient's identification number, date, and it always has the heart rate, and then it tells you some things. And of course, you always put in heart rate and blood pressure. And also, actually on telemetry, oopsies, actually on telemetry, there's more information. Yes, Ms. Phoebe, question? You can unmute yourself. Question? And someone raised their hand, I saw. No, we're good? Well, because if you think of it, the question, you could put it here in the chat. And also, I can, if you need for me to stop, I can do so. Alrighty, next. So let's look at it. It's going to make a nice little review for us. So what are the names of the standard limb leads, right? Okay, now we have two choices, right? We have the bipolar or unipolar. And remember the standard ones, right? Those are the ones with the Roman numeral 1, 2, and 3. Those are the bipolar. Roman numeral 1, Roman numeral 2, Roman numeral 3. How many chest leads are there on a standard 12-lead ECG, right? It goes, there are 6. So you could sit here and you could do this, this little quiz on your PowerPoints. I thought these are kind of neat that your former textbook did. So let's look at the ECG machine. Nowadays, less than 10 pounds. Some of them are even less than a pound because now there's these new ECG machines that connect right into an iPad. I just went to my doctor for my physical a couple weeks ago, and hers plugged right into her iPad, right? And all it was the wires, and then they plug right into the iPad. And I've also seen in the hospital, it plugs into like this sensor, and then it goes right into the computer. But they all produce multi-channel. So you'll see something like this where it has all the leads all at once. And it doesn't take long. So of course you got the input part. That's the part where you put the patient's name and all that stuff. Now be very careful and take your time to do that, because nowadays, remember I mentioned telemetry, it goes right into the system. Like many times the ECG isn't printed out on paper anymore. It's printed out electronically. And if you put the wrong number or the wrong patient name, that file will go to the wrong patient. So then later when the doctor or the cardiologist wants to go look at it, then there's going to be a problem, okay? And you also kind of always check, because did the signal go through? Did it process? Just because you saw it on an output display, did it save? It's just like the basic rules of, you know, when you save a file, that kind of thing. Of course, and then, I don't know what they were talking about storage, but you try not to put anything electronic in any severe environment, like, you know, like someplace where it's too hot or where it's too cold. And of course, if anything goes wrong, remember, communicate to your chain of command immediately or put it in the chart immediately. Now, who interprets the ECG? Not the technician, not you. Okay, so if the patient asks, does that look fine? Okay, he goes, no, well, and he goes, the doctor will be in shortly to answer all your questions. You just tell them, because I'm simply the technician. I'm not allowed to, I guess I'm not allowed to discuss with you, but the doctor, I'll get this to the doctor immediately so the doctor can talk to you, right? And they're gonna want you to say something. But remember, who's the only person who can speak diagnosis? The physician or the DNP in charge, okay? Now, the speed. Sometimes in cardiology, you want to speed it up and slow it down, but typically for a typical ECG, it's running at 25 millimeters per second. Okay, so when we play around with the machine in laboratory, I'll show you exactly where that button is. You usually don't mess with it, but sometimes, you know, you just got to make sure, like, especially if the ECG looks funny, look at the paper speed. Okay, now troubleshooting, right? Yeah, like I said, the cardiologist or may want to play with the speed. Sometimes we like slowing it down. Sometimes we like speeding it up because we see different things. Now, the gain, again, the gain is how high or how low the waves are. Leave it at 10 millimeters per millivolt. I almost never, I don't touch the gain. You just make sure it's at 10 millimeters. Now, what's an artifact? This you don't usually play around with, but let's get to, are they gonna show the artifact? Oh yeah. Let me write that down, and then I'm gonna show you what artifacts are in a minute. I'm gonna see if maybe Dr. Nua included it in another PowerPoint. Now, on the LCD screen, you're gonna see somewhere, you're gonna hear beeping. It's gonna sound like an alarm. When you put the leads the wrong way, newer machines, like in the last, machines from the last 10 years, they'll start beeping, right? And it'll tell you something's wrong, okay? It analyzes the leads. But again, the best person is who? The best person to check, who's the most accurate computer in the world? You. So you always check. Heart rate limits, there's also audio alarms for tachycardia and bradycardia. They're annoying. Lead selector, that's not important. Let's go, I think. So those basic numbers, what do you call that? You need to know those. Okay, these are electrodes. These ones with the buttons, they're old school. The new school ones, they clip on. There are also other ones that are already pre-done, especially in the ER, it's faster, and they just plug right in. But the ones that you'll most likely see are the ones with those little clips, and then they connect into the stickies. Those stickies are called electrodes. Please do not call them stickies. A lot of physicians and technicians will look at you like there's something wrong with you, right? Call them electrodes because that's what they do. They're sensors. And 3M makes the really good quality ones. The really good ones you use in the cardiology office are 3M Golds. Gold is a very, very good, I forgot, is it a conductor or a resistor? But whatever it is, 3M Golds are expensive. They're like 2-3 times worth more than, and also they just conduct the signal very, very well for whatever reason. You know, just like there's brands, but 3M is most common. We already talked about that, and then of course they're disposable. Oh, the other thing I also mentioned, I think I mentioned last week on the lecture. This is the world, this is the new world of COVID now. So you mask up, you glove up for this procedure. In the past, it was non-invasive, so you didn't have to mask up, you didn't have to glove up unless the patient had an infectious warning or they have signs and symptoms of an infection. But nowadays we have to do that. Okay. These electrodes are all disposable, of course, and you can throw them in the normal garbage. But if you're in ER and they're blood soaked, throw them in the biohazard. They have expiration dates, but over the years, I've had old boxes that were like 5-6 years old. They're fine. The expiration date isn't as important as, like, let's say, expiration date for meds and chemicals.
May I ask a question on that?
Yeah, shoot.
So I know obviously they're different than meds and stuff and the, obvious difference with the expiration date, but why would they put an expiration date on it
Because
if
it
it was?
has stickies, you
Mm-hmm,
know, like, and the ones I tested were 3M Golds. They were 5 years old and they were fine.
mm-hmm,
They have an expiration date because, like, if you got a sticker,
mm-hmm.
it loses its stickiness, right?
Oh, so it's not for the lead itself, it's for the adhesion on the lead.
The adhesive, and also, yeah, because, metal is metal. It doesn't go away, you know.
Right.
So,
Okay, that makes
I
more
think,
sense.
I
I
think
didn't
that's
know
it
they had an expiration date.
because that's also the other thing I have to mention since you asked that question. You
Mhm.
try to always put it back in the sleeve, like in the little wrapper that it comes in, because the cheaper ones, because odds are you'll be working for a cheap doctor, and they get the cheaper ones, right? Unless it's cardiology, they'll always get the good ones. Even with the good ones, you put them back in the sleeve so they don't dry out, okay? And you don't put them on. I remember I got chewed out once because I put the packet on a heater. And my office manager was like, "What are you, stupid?" And I'm like, "Oh man," because I didn't know. Because when you're not treating your job as a profession, and when I was an MA, my first year, I was treating it like, "Oh, this is just another stupid job." It isn't. This job we have is very important, and there's a lot of little things that could affect the diagnostics and the management of our patient. That's why the 4 years I was a medical assistant, it was a wonderful training ground, and it also reminded me how important this job is. Uh,
Yeah.
and and like I said, my life was going nowhere until I became an MA, and then this
Yeah.
led to one thing, led to another, led to another. Next thing I know, I got these two letters at the end of my name, right? So
Mhm.
even it's little things like this, these are the little things, these are the details that you got to pay attention to. And do
Right.
not mix electrode types. Let's say, for example, I got the cheap set and I had 3 extra, and then I had some, I had 3M reds. Reds is another type. It's the label is called red, right? Don't mix them up. If you use, and I use the same pack, and if you have any extras, you always keep them aside just in case you needed extras. Because another thing we'll begin talking about in laboratory, there are certain cultures that they like putting body oils, especially a lot of people from the Southeast Asian basin, they love body oils, and it totally messes up the stickiness to the EKG. But we'll talk more about that later. Right, I think I'm jumping ahead of myself. Let's go apply your knowledge. We're good. Now, as a side note, if you got somebody who's a little bit, for lack of a better term, slippery, maybe they're sweating, they're nervous, they're in emergency room, or they have some oils on them, right? Or some body wash on them. You just use, those little isopropyl alcohol pads, 70% isopropyl alcohol pad. You don't wash them down with it, but the area that you're going to put the electrode in, just wipe it down, and then allow it to dry, and it should stick fine. Now, what is so important about the ECG paper? Well, it's the lines. That's what's important. And we remember last week, right? Of course, always obvious. Keep your backups. Remember, and tracings now are electronic. And if they're not electronic, we got to scan them anyway, right? So all medical, here's a lovely RMA AMT answer. When you guys take your medical assisting registry exams, all um, what was I about to say? All medical records have to be kept for at least 7 years. Oh, by the way, at least 7. You guys know I haven't practiced in what, 9-10 years? It's like 9-10 years now. I still get calls from other lawyers like, hey, do you have, and um, in 2002, I took all of my paper charts, right? And I paid these 2 high school kids like $10 an hour to scan them all, so that if anyone, so I have records of every single patient that I've ever seen as both a physician, a resident, and an intern. And they're still always asking me like, hey, by the way, and that's why I've never been in any other medical legal issue because I can easily cough up, what do you call that? Data, evidence. Right. So of course, you know, make sure to keep the paper and all that stuff out of light. Because by the way, the paper, especially the old school paper, it's heat sensitive. Because if you remember the dot matrix papers, dot matrix is like the cheapest way to print things without expending ink, but it utilizes heat. So I remember when I was first teaching, I had a student. She sat on hers, and then it got all, and it was a final exam, and she got all bent out of shape because you couldn't read the trace anymore.
Can I tell you a funny story about that? Since I had something, I guess, somewhat similar. So when I was taking my EKG class, when we went into the hospital for our, stuff we had to do, we got to keep some of the leads and take them home and use them, as extra points for a test or whatever. Mm-hmm. And the guy said, "Don't iron them." Well, guess what I did?
Yeah, or like you put it, or you put it down on like a heater, or you put it, and then you're like, oh, I'm so stupid. And that's why I learned early, scan it, get it in electronically, so nothing. And also, it's also nice because when we're in laboratory, keep your traces, because that's your labor. And many students, they put it. I wish I still had my first trace. I remember I had my first trace. I just threw it out. I should have kept it because it would have been kind of cool because, 10, 12 years later, I became a doctor. Wouldn't it be neat to look at and go, hey, that's when I barely knew what this stuff is. Now I totally know. Now I teach this stuff. I was one of those people who don't keep things, but now because of my wife, I'm a hoarder now because I like looking back on things now, but it's now better to do what? Just scan everything, get everything electronic, so you can look at it. And it's also a nice review. So we mentioned last week, right? If you read the ECG paper left to right, that's time. And if you read it up and down, that's voltage or gain. Now, the paper is cut up into little boxes and they're all like a millimeter long. So if you read it up and down, and it says 1 centimeter is 1 millivolt. Now, there's a better way to look at it. Well, where's the, go? Man, they're doing it. See, I'm gonna there you go. Oh, much better. So if you look at this ECG paper, do you see how there's a big red box? Does everyone see the big red box? And then you have 1, 2, 3, 4, 5 little boxes. So reading the voltage, also known as the gain, is easy because one of these little boxes is 1 millivolt. That's easy. So we see, if I ask you, what's the positive deflection on this P wave, right? And you'll tell me 1 millivolt. What's this deflection, the positive deflection, on this QRS complex? So let's count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So that's 10 millivolts. What's this deflection on this T wave? 1, 2. Okay, right? Is that hard? Nope. Now, it gets a little tricky when we start talking about time. Now, time is in seconds, right? From left to right. So one little box is 0.04 seconds, okay? And 1, 2, 3, 4, 5 boxes is 0.2. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 boxes is 0.4, so on and so forth. So if we're looking at, let's say, for example, I want to look at this PR interval right here. So that's the measurement of the beginning of the P wave onto this QRS complex. So if I look at it, it's 1, 2, 3, around 4 boxes. So that's 4 times 0.04. So that's 0.16 seconds. Right? And it's within normal because the PR interval is 0.12 to 0.20 seconds. So this patient's PR interval is normal. This patient doesn't have a heart block. But what happens if this P wave is all the way over here, right? And I have 0.24 seconds. That means there's something wrong. So what could I ask on an exam? I could ask deflection, upward, that's voltage, or I could ask time, left to right. I could ask you, what is the amount of time of a single 1 millimeter box? And you'll tell me 0.04 seconds. I could ask you, how much is one big box? And one big box is 1, 2, 3, 4, 5 little boxes. And the answer to that is 0.20 seconds. Does anyone have any questions on this? Because this is a tricky one. I actually, when I was in MA, I told you guys, I went to like a crummy school that just told me, hey, put the stickers. That's what they called them. The lady wasn't, I don't even think she even had a undergraduate degree. She just went, and I remember her name is Miss Ross. And Miss Ross was like, she was really obese. And it was when she did EKGs, she got really tired and started breathing funny. And the whole entire time I'm thinking, she might need an ECG. I was right. She got a heart attack a couple of years later, someone told me. Now, let's look at heart rate. We're going to be doing this also in the lab. There's 3 methods. And remember that I told you that the long lead 2, right? Lead 2 is the best way to look at your heart rate. That's the way the machine calculates your heart rate. And also, just so you can make sure the machine's honest, you can calculate the heart rate. So there are 3 methods to calculating the heart rate. They're called the 300 method, 6-second method, and the 1500 method. So let's look at these 3 methods. But first, let me back out of this and let me show you. Let me show you what I'm talking about regarding what does a long lead 2 look like. So if we see this, okay, this is your typical multi-lead, and you could see that it has all the players. You have your limb leads. Here's your bipolar, 1, 2, and 3. You have your augmented leads, AVR, AVL, AVF. You also have your precordial leads, V1, 2, 3, 4, 5, 6. You count them all up. Those are 12 leads or 12 views of our heart. If you could see here, you see these little square things? These are calibration towers. They have to look all the same. And they look pretty good, don't they? So do you see you have a short lead 2 here where it only has like 3 waves here? But you also have a long lead 2 right here. Now this is what we use to calculate rate, okay? Or how fast something goes. Now that I got you here, might as well look at what normal looks like. So this is what normal, or what they call NSR, normal sinus rhythm, looks like. Now, the first thing you have to notice, the calibration towers are all good. The next thing you have to notice is on leads 1, 2, and 3, right? Do you see how, well, on 3, not quite, but in theory, all 3 of them, the leads should be upright. Now, if you look at AVR, AVL, and AVF, right? AVR should be inverted because it is moving away from your heart. AVL and AVF, they're moving towards your heart, so those cameras should be upright. You'll also notice V1 through V6, do you see the QRS complex is upside down? This is QRS, which your ventricles. So the closer and closer you get to your left ventricle, do you see how it starts inverting? And then it gets bigger and bigger, and then when it starts going far away, it gets a little bit smaller around V6. That's called the progression of your precordial leads. So you look here, 1, 2, and 3, leads are upright. AVR is upside down. V1 through V6, right? There's progression of your QRS. And if you look at the long lead 2, doesn't the spaces in between, this is a QRS. So these points are called R waves, R. Do you see how they're all even? And then that's how you could tell your physician or your whoever the lead technician is, you could tell them, hey, it goes, that's what NSR looks like, or normal sinus rhythm. And normal sinus rhythm means what comes up must go down. So everything is even Steven. So now that when we look at this, hold on, it goes, I gotta answer this. Thank you for calling Stratford University, Alexandria campus. Dr. Garais speaking. How can I help you? I can give you a number that you can call, and that is our registrar. I cannot answer that question here. Are you ready for that number? Okay. You call this same number, but you dial in extension 4206. And dial the extension 4206, and that's the office of the registrar. Now, no one's on campus due to COVID, but they are monitoring their phones regularly. Okay? All right, have a good one. Thanks. Bye. Yeah, go away. All right, sorry about that, kids. Wait, did I put on pause? Great, now I got me on your lecture answering phones. Lovely. So let's now look at, love it. Remember I told you guys don't multitask, but what am I doing? Multitasking. So sue me. Let's go here. Play from current slide. So remember that long lead QRS? This is QRS. So one way is the 300 method or the R to R method, and you're counting big boxes. So if you count, how many big boxes here? 1, 2, 3, 4. So there's 4 big boxes that fit in between the space of this one set of waves and this one set of waves, or the distance between the R to R interval. So, and it's called the 300 method because you take 300 and then you divide it by those 4 big boxes. So 300 divided by 4, and the magic number should be, I think, 75. Or 75 beats per minute. Another way to calculate is called the 6-second method. Now, you'll see these really heavy hash marks, and every time you see these heavy lines, from line to line, that's 3 seconds. So from here to here is 3 seconds, from here to here is 3 seconds, for a total of 6 seconds. Now, the 6-second method is easy. All you have to do is count the complete QRS complexes. So this doesn't count because it falls outside. So this 1, 2, 3, 4, 5, 6, 7. It could be 8. Yeah, we'll call it 8. So we see 8 QRS complexes within 6 seconds. All I have to do is take that 8, multiply it by 10, and then I have what? 80 beats per minute. Okay. So that's also another quick and easy way. Not as accurate as the 300 method, but it's quick. So do not count incomplete complexes, because that's why this is like debatable. But heck, I'd count it.
Let me ask you another question on that. Can you go back to the other page?
Previous. Yeah.
Okay. So before the number 1, the one that's not labeled, would that be kind of an one as well?
This would be no. This is a no-go because we started where? Here,
right now.
right?
Okay.
Like the only debatable one is this 8.
Okay.
I was like, it's kind of on the line. But me, personally, professionally, I'd count it.
Okay, count the
I
end.
wouldn't, and on an exam, I wouldn't put, is it 80? Is it 70? Is it 90? I wouldn't put that close. I would say, I would ask you, by the method, would you do 8 times 10, 6 times 10, or 10 times 10? And of course, the best answer would be 8 times 10.
Yeah, personally, I would do the 8 because I mean, it like you said, it's and, but it's still within the line. So I would do the 8 by.
And also, come on, the difference between
Yes.
70 and 80 beats per minute. But again,
Yes.
why are we doing this? I'm not doing this to put it down on a piece of paper. I'm doing it to make sure the machine isn't messing with me.
Right.
Those of you who've been in my laboratory class, I talked about something called the GPS syndrome. Maybe you guys saw that commercial where this couple, they're driving down the road and the wife notices that they're about to drive off a cliff. And then the GPS keeps on saying, go straight for 2 miles, go straight for 2 miles. And the husband goes, GPS said go straight. That problem happens at the hospital all the time. How many times I've had patients get worked up because the technician, the nurse, or the doctor went, no, but the computer told me. Yeah, how about the computer in between your ears? That's the one that's important, okay? So if you see 8 traces like this and the machine's kicking out 100 beats per minute, you should be asking yourself, maybe the calibration's wrong, I should redo this trace, okay? Now, the 1500 method is the most accurate of them all. They measure little boxes. So just the 300 method, we did the big boxes. But see all these little boxes, blip, 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 blip. There's what, 30, I don't know how many. You divide it into 1500. So you put in your calculator, let's say this was like 36 small boxes, 1500, press the divide button, then 36 or 38, whatever this number is. I can't read it even with glasses. And then you press equals, okay? Remember to do the 1500 first, then divided, then how many small boxes. And that's the most accurate method to check your machine, and that's called the 1500 method. So to recap, you have 3 methods. You have the 300 method, the 1500 method, and the 6-second method. 6-second method is the fastest. The most accurate is the 1500 method and the 300 methods in between. Each large box is equal to how many seconds? 0.20 seconds. Or you could take 0.04 times 5, because there's 5 little boxes in one big box. And large box, 0.20, we talked about that. On my knowledge, identify the heart rate in this 6-second strip, right? See this one, there's a borderline, right? I'm not gonna count this guy. This one's outside, so I'm only gonna count this one. 1, 2, 3, 4, 5, 6, 7. 7 times 10, 70 beats per minute. Okay. Now, when you go home, pause it, or and then don't reveal the answer. Okay. Try it on your own. Okay. So I think we shouldn't do the summary. We're good. Alrighty. So there's also a nice little thing that Dr. Nua has in here. There's this is a video. Oh, this is a nice little picture. And you could easily find that as well. And that's your PR interval. But what you need to know is from today is the box is going up and down. That's your deflection or your voltage or your gain. And the box is left to right. That's your timing. Okay, it's a nice picture. You could, and what else is important? Of course, do the, I don't know what this is. I'll remove this. Now, there's this lovely video here.
This is Tyler. Tyler, with Grammarly's help, is writing an email to his boss, Anita.
How's this? Learn how to do English instead of Grammarly.
Hello, welcome to Chapter 1 of the ECG course.
Okay, so this is like kind of like the same exact thing that I went through, but it's also another alternative video that you can do, okay? Just making sure the link works. And the other one is the ECG leads, and let me see if it works.
Welcome back.
Good. And this was the old textbook. Oh, Dr. Noah's really digging, right? And it's the old textbook that we used to have. But again, we can use it and pick it up for you guys. All right, give me a moment, and I'm gonna stop the recording.